are on our... Hello, welcome everyone. Welcome. We're going to give you a minute to get in and get situated. Please tell us who you are in the chat. Tell us what site you're from. Well, welcome to our Navigator Focus Series, Harm Reduction for Navigators. We know that this is such a top #1 training for you guys, and we're so excited to have our special guests today. So we're going to give it just a minute or two so everybody can log on, and again, tell us where you're from. We're really excited for our summer Navigator Focus Series, and we have a whole new focus series starting in September. We're going to take August off, so we want to enjoy some summer vacation also. So we will be restarting Navigator Focus series in September. So really excited to have you here as people log on. Let us know in the chat where you're from. And we're going to get started because I know we have a lot to cover today. Like I said, this is always a topic that is near and dear to the hearts of our navigators. We can never get enough harm reduction training. So here is our copyright, and you are welcome to share. You just can't, you can't alter. We always share. So for the best experience today, please connect to your computer to a power outlet, close unnecessary windows. We don't want it to freeze. We don't want you to come in and out. One thing that's really, really important is that you address in the chat box to everyone. Very important, because if you have a question, only the panelists can see, and everybody else, I'm sure, is asking and wants to know the same thing. Okay, so again, just check. It's a little blue, the little blue banner in your chat box, and just make sure it says to everyone. There are closed captions, and we will, again, if anything happens, we will follow up with you if we cut it short. Today's agenda, wow, this is what we're doing. We're welcoming and introducing ourselves. I'm Sherry Cisneros, and I'm the Navigator Program Director for California Bridge. And again, this will be our last, sad to say, Navigator Focus Series for our BHPP. We will be entering a new round of grant funding, which starts September, and that will be the BMP. If your site has not, I repeat, has not signed up for the BMP new grant, you are entitled. If your hospital has an emergency room, please make sure you sign up. All right, so what is California Bridge? Just a reminder, 24/7 access to high quality treatment of substance use disorders. That is our goal. You guys are killing it. Right now, we have over 176 hospitals. I believe it's more like up to 186, but we haven't updated the slides. So we're so excited. We're expanding, and with our new BMP model, we are going to go to 300, you guys. So we're only expanding. What is the California Bridge model? I always like to take a minute or two just to remind everybody, our whole model for existence is we're revolutionizing the system of care. Number one, the first pillar is low barrier treatment. Anybody could come to your emergency room and request buprenorphine, right? Very low barrier, don't need a urine drug screen. They can say, I'm in withdrawals, I am having symptoms, I need treatment. The next two pillars are specifically to our Navigator connection. That's doing a warm handoff to the treatment facility, whether it's telehealth, getting them set up to the whatever outpatient, inpatient treatment or detox. And then a culture of harm reduction. That's why we invited these wonderful people today, is to engage your own hospital with the culture of harm reduction. So without further ado, and again, if you go onto our California Bridge website, all the information for our new grant Bridge Navigator program is on our cabridge.org. So please, we encourage you, if you have not finished your application for the grant, very simple, you guys. So please, please log on and sign up for your Bridge Navigator program. If you don't take care of it, ask your supervisor, have we signed up? We are giving money away. So welcome all my friends. My chat was enabled, but it looks like everybody's signing on. Christina at Sutter Santa Rosa, hello, nice to see you. Wendy, our mentor, is here. Tanya from San Diego. Everybody's here from all over California, so we're really excited. These are our objectives today for those who need CEUs. And it is my pleasure to introduce, and the person who helped me and said, we need to do a National Harm Reduction Coalition training in July. So I am honored to have Charles Hawthorne help me with this Navigator Focus series. And if you don't know Charles, do not know. I can't imagine they don't know you, Charles. But if you don't know him, he is our expert here at California Bridge for all things Naloxone Distribution Project and, of course, harm reduction and racial equity. So I'm going to hand it to you, Charles.
Awesome. Thank you, Sherry. Hi, everybody. Thank you for that wonderful introduction. Like Sherry said, I am the California Bridge Equity and Harm Reduction Project Manager. So if you're having any questions at your hospital around starting a naloxone distribution program, doing harm reduction work, supporting your hospital and doing more equity-focused work, anything like that, please, please, please reach out to me through either your Sun mentor, through Sherry, just sending us an email directly, and I will absolutely get back to you. I'm on the Slack. So feel free to send me any messages. And so today it is my pleasure to introduce my colleagues from the National Harm Reduction Coalition. So I used to work with the National Harm Reduction Coalition in the role of supporting them with doing trainings and supporting syringe access programs across the state. I am so happy to have them here today. So if you want to go ahead and hit the next slide. Today we have Savannah O'Neill, who is Associate Director of Capacity Building, and then Jenna Haywood, who is the Associate Director of Community Mobilization. Together, they have done a lot of work to bring together the California Syringe Access programs and really start building a network of care for people who use drugs in the state of California. A lot of the work that I've been doing with programs through my California Bridge work is really modeled off of what they do. And they have some really incredible trainings that they've actually put together. They've been the California Bridge harm reduction leads from the time that it was begun. And so I'm really excited for them to for you to hear from them. They have a really great understanding of the Navigator role and what you can do as far as harm reduction within your role. So I'm going to go ahead and turn it over to them to get started.
Thanks so much, Charles. It's so sweet to have you introduce us. And I know that many of you have seen us present over the years and have also seen Charles when they were in their previous role with us. So it's just nice to be able to continue to share this space. I know Jenna's pulling up our slides, and yeah, we're really excited to be here with so many of you. And I'm sure there's folks we don't know. So to start, we're going to talk about foundations of harm reduction today as it relates to the Navigator role and harm reduction in the emergency room. I'm Savannah O'Neill. I'm in the role of Associate Director of Capacity Building. And as Charles said, I have been in that role for 4 years and been working with Bridge since the inception. So it's really been wonderful to see the progress and growth. And my history before coming to National Harm Reduction Coalition is working in direct service. I'm a social worker by training. I've worked in health clinics and treatment centers and methadone clinics and HIV testing, sort of across the spectrum of places that people who use drugs engage with from a harm reduction perspective. So that's kind of how I come to this work, and I'm excited to be here with you today.
Yeah, hi everybody. Can you see the slides? Okay, cool. Yeah, my name is Jenna Haywood, and it has been it's been a while since I've had the opportunity to work with the Bridge program, but like Savannah said, we did it a few years ago. It was mainly just the two of us. So it's been incredible to see this program grow. My work at NHRC now mostly focuses on community mobilization, so advocacy, policy work, coalition building, which I see as just critical to be able to get programs like California Bridge going and sustained and be able to center this work. My background professionally was in organizing and political mobilization and things like that, but I am I have lived experience as an injection drug user and somebody who was actually on bupe for many years, and had experience navigating bupe before it was nearly as accessible as it is now. And so it's been also really incredible to see and be able to refer people I know to go in and get on bupe, when that has, it has not been, for me, I remember being put on a wait list. And now, that's pretty much unheard of to have to wait to get on bupe. So a lot of progress and just really excited to be here. Wish it was in person, but this will have to do.
Great. So if you want to go to the next slide, Jenna, we'll just do an overview for those of you who don't know. We are the National Harm Reduction Coalition, and we do a bunch of different things. Probably about over 5 years ago, we adopted a North Star statement, which is National Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms caused by racialized drug policy. So a North Star, right, that's what we're aiming for. And we do that through these 5 kind of buckets of work. We do policy and advocacy work. As Jenna said, we do state level, local level, and national level policy and advocacy to create better policies and budgets for people who use drugs. We host national and regional conferences. So we typically have an every other year national conference, which has been on a hiatus due to COVID and is back in San Juan, Puerto Rico this October. We also do regional convenings. We do trainings and technical assistance like this to really help people troubleshoot what's coming up in their spaces, what they're seeing, how they implement new programs, help build new programs. We do a lot of work on overdose prevention and naloxone historically for the last 30 years, and run the DOPE project in San Francisco, which is a model program for directly distributing naloxone to people who use drugs. Then we do resources and publications on our website. We have a bunch of different things that you can look through to get information. So that's who we are. Luckily, I feel like I've gotten to work with a lot of you, but in case you didn't know us, and again, what is our role? So we've collaborated since the beginning. We provide training and technical assistance to California Bridge, to substance use navigators, and to individual hospitals to ensure services center harm reduction philosophy. And that's been just a huge, it's been incredible to witness how California Bridge has done that compared to other treatment initiatives in a way that I've witnessed be really successful. And we also do a lot to facilitate relationship building between local syringe service programs and hospitals to support that bi-directional network of referrals. So if you all don't know where your local syringe service program is, don't know where harm reduction resources are in the community, we're happy to help support you to understand that, to introduce you to people, and to make sure that there's that connection. If people who are in syringe service programs know people who want to access bupe, or if you know someone who needs access to safer drug use equipment and you can't provide that, which we'll talk about later in this. Yeah, and also supporting the integration of tools into the emergency room. That's who we are and what we do. So first, we like to start every foundations training with just really this question, which is, why do people who use drugs? We're going to put the link to the slides in the chat. If you want to open them, you can actually just type right into those bright squares on slide 4, or you can put it in the chat and we'll transcribe it into the squares. So why do y'all think people use drugs?
Or you can just come off mute and say what you want to say, and we'll put that on there also.
Because they're fun. I always love when that one's first, because they're fun. Experimental. Oh yeah, it doesn't sound like they have mic access. So either in the chat or into the slides directly. Coping strategies. I'm gonna go slow for transcription, but y'all can definitely read them coming through in the chat. Self-medication, I'm seeing many times, self-medication to numb feelings, to numb a feeling, trauma, grieving, boredom. Yeah, so people might, to cope with emotional or physical pain. This is so great. I'm seeing so many in here. So we're seeing lots of different kinds of trauma, survival. So yeah, survival could be you're living outside and you need to stay awake at night, or you drive overnight and you need to be able to stay awake, or it could be surviving trauma, being able to live, you know, through that moment. Also, I'm seeing some like peers, so following friends, negative influence. Also, maybe that's just what's normal in your community. It's accessible, it's around you. Your family uses drugs to socialize. Also preventing withdrawal, so physical reasons why someone might still continue to use drugs, to disassociate. I'm going to scroll back and see what I'm missing. To escape from reality. And as LaToya said, if anyone wants to come off mute and add your voice, you can definitely raise your hand and people can call on you. Because it's forced. So I'm curious what you mean by that, but I definitely know people who either have been forced in abusive relationships or coerced in some way. Immediate gratification and stimulation to study. We have to stay awake in safety. Let's see if I can unmute you. Can someone unmute Oscar?
Hello?
Yeah, go ahead.
Oh, I'm sorry. So I wrote immediate gratification and stimulation. You know, I think a lot of what I'm noticing in a lot of the points that people are making is that the reasons change as the disease progresses. So in early stages of the disease, yes, experimental, recreational, to be accepted, that sort of thing. But as the disease progresses, the reasons why a person uses also change. So then you start to self-medicate in later stages. Then it's coping, you know. But the point that I'm just making is that the reasons for using, and some people even mentioned like using against your will, meaning they have the desire not to use, but they use anyway. That reason happens in the very late stages in the progression of the disease. But I think the reasons why people use are dictated by what stage of the disease or what stage of the progression they're in. That's all.
Yeah, no, it sounds like you're saying people use for different reasons over time, and that can change depending on how your relationship to drug use changes. So that can be, you know, first it can start as experimentation and then become more debilitating, and that people are going to have different reasons at different points, maybe even with different substances.
Right.
Yeah, and just wanted to add, well, thank you. I see that Alejandra added this in as well. Oscar, I think that, you know, thinking about someone who has a substance use disorder versus somebody who does continue to use drugs recreationally or for pain management or whatever the reason might be, that just making sure we're differentiating between or making sure we're acknowledging the nuance that not all drug use is a substance use disorder. And in fact, most people who use drugs don't have a substance use disorder.
Right.
And but it segues into the next slide, which is about why people don't stop. And so I think that sometimes is where, you know, for me in my experience, realizing that or kind of getting more into the category of substance use disorder for me had a lot more to do with, can I stop when I want to or not, versus why am I doing this to start, you know?
Yes.
Great. So yeah, maybe we can go into that. But yeah, I think, you know, knowing that we also are going to do different things depending on if someone can't stop using a drug or if they're just recreationally using, right? How we're going to approach people, what services they need, what support they need are going to be different. So that's another reason to differentiate. So as Jenna was saying, why don't people just stop using drugs? Because they're chemically dependent. So because they're trying to stave off withdrawal, they're physically dependent, they'll have negative impacts if they stop using physically. And I think, that was some of what Oscar was saying. Someone might be in physical pain or be self-medicating. It works for them, so they're not having any issues from their substance use, so they don't need to stop. They don't want to. They don't have the support or resources or avenues to stop. They don't know where to go for help. So again, they just don't know what to do. They're scared, stigma, housing issues. They don't feel safe. Their conditions are still the same, right? Maybe the conditions that cause people to use drugs, like needing to stay awake, like being in a family that has drug use around, those things haven't changed. So why are they going to stop using drugs? They're self-medicating and they don't have an alternative. So again, like the conditions haven't changed. They don't know where to get that same need met anywhere else. They can't access psychiatric medications. They can't access stable housing. They don't have a job that provides them purpose. So all of those things. Low emotional intelligence and emotional regulation deficit. So it seems like some of that is like, again, thinking about what are our beliefs about people who use drugs. So knowing that people have huge varied experiences. So I would just want to be aware of the fact that many, many, many people use drugs. They're scared to feel those feelings. Their feelings might feel overwhelming. They're being enabled. They may sell drugs to survive, so it might not feel like an option to stop. So again, it's part of their economic circumstances. It's part of their family life, right? So like if you're gonna not be able to go home for the holidays because your family uses drugs, you're gonna lose that peer support. I sometimes will tell a story about when I worked at a methadone clinic with someone, and literally the only person he saw was his drug dealer. And without that, he was so impacted by isolation. So continuing to buy drugs and see that person, his life actually felt better than when he stopped using and he was completely alone. So people are making choices about what really feels good in their lives too. Lack of dopamine. So again, kind of that physical dependence, not having alternatives. It's a way of life they know. Great. Anything you're seeing you want to add, Jenna? Suicide prevention is kind of what I was going along of, like it might be supporting an emotional need.
Yeah, I kind of added a chunk of them under this mental emotional dependency piece, being like some kind of, it is meeting a need for either, physical, to avoid the physical withdrawal, but also there's the other, like someone said, suicide prevention or anything related to the mental or emotional part of it. So I think this is a really good diverse list, and again just points out that people use drugs for lots of different reasons and they keep using drugs for lots of different reasons. Anything here to add?
Yeah. No, I think we're getting a couple more coming in the chat, but yeah, I think that's really our takeaway, is that it's incredibly diverse. And if we responded to everyone as if they use drugs for the same reason and don't stop for the same reason, we would miss the majority of how to show up and support people. So that's sort of a core tenet of harm reduction, which we're gonna go over a little bit more in detail right now.
Okay, so many of you probably have some kind of understanding at this point of what harm reduction is, and so we're going to talk a little bit about the harm reduction approach. And the definition of harm reduction is that it utilizes a spectrum of strategies to reduce the negative consequences associated with drug use, sex work, and other behaviors. We often mostly think about it related to drug use, and I think that's what we'll be primarily talking about today when we talk about harm reduction. And so sometimes that might look like safer techniques, being able to have access to sterile injection supplies or sterile smoking supplies, or naloxone to reverse an overdose. That would be considered safer techniques. Also having access to education materials that can teach somebody how to use drugs as safely as possible. Managed use is also part of that spectrum. So that could look like, you know, having support networks in place so that a person is working on goals to reduce their use or to stop using one substance and only use another substance. And then abstinence is also on the spectrum. So that would mean not using drugs at all, or for some people that can also look like not using a particular substance at all. And we often don't think about abstinence as part of harm reduction, or it's not commonly thought of that abstinence and harm reduction fit together. A lot of times they're seen as kind of these like separate approaches to drug use and to substance use disorder. But here we look at abstinence as part of that spectrum. For some people, abstinence is their harm reduction. For others, it's managed use. And for others, it's just safer techniques. And that can, of course, change for people over time. But harm reduction is not only just about safe supplies and kind of the specific relationship to drug use. Like Savannah mentioned, related to the North Star statement that NHRC really uses to guide our work, the harm reduction movement is also about social justice. It's looking at public health work as one and the same with social justice work, and really acknowledging the fact that most drug-related harms have to do with things like racism, stigma, and criminalization, more than they have to do with the actual dangers of using the substance itself. A lot of what you just said when we asked why do people use had a lot to do with the social conditions that people are in. It had to do with the support network they had. It had to do with their financial situation. It didn't necessarily only have to do with the fact that substances are available to people and that they in of themselves are creating these harms. You'll hear we'll go over the principles of harm reduction, and one of them is, being pragmatic and realistic, that there are, of course, harms associated with drugs themselves, but it's really important to think about harm reduction as so much broader than that. And so in that way, it can be applied to so many things, not just drug use. And often people are dealing with a lot of things intermixed, right? We just talked about why can't people stop? Well, if they don't have housing, if they don't have support, if they don't have treatment for their mental health condition, if they don't have therapy, or they're not working through their trauma or whatever it is. And so in that case, just saying, oh, here is, the solution is to be abstinent and we're not going to work on any of those other things. The drugs are the only problem. That's not a realistic way to look at this any longer. It never really has been. So we talk about ending inequality and oppression, fostering health and liberation, really lifting up the health and dignity of people, their autonomy, looking at them as whole, complete, wonderful people who deserve all of the healthcare access that anyone else deserves. And really then, with that in mind, bringing them into all the decisions that are going to be made about them. So really honoring them as leaders in their own lives and leaders in this movement, and making sure that we're centering the most impacted in the work in order to really get to that transformative change, to that system, community, structural level change. So if there's one thing you take away from this whole thing today, to me, the most important is you are going to be out there, you are out there working with people who are probably dealing with all kinds of stuff, and just, remembering this when you're going into it, that maybe it's frustrating that you can see that somebody's drug use could, that changing somebody's drug use could really help their life. And yet, just trying to really center that there's so much more going on, and how can we keep always remembering to try to respect the health, the dignity, and the autonomy of people who we're working with. So we're going to get into the principles of harm reduction. But before we do that, we like to show this video so that you can kind of have something, look, I want you to pay attention to what's happening in the video. What do you see going on? How do you see people in this video being treated. And then we'll talk about it a little bit, and then we'll go through the 6 principles of harm reduction. So I stopped sharing for a second because, whoops.
This area was home to one of the largest skid rows in the United States. A lot of bars, a lot of drug trafficking, and it was particularly prevalent on my block. So everyone around me was caught up in drug use of various kinds, and I got caught up in it too, so, you know. I want to give you today's quote that I stole from Facebook. It pertains to my Hep C quest, and it basically says that our mission is impossible, so what are you waiting for? Let's get started. I had a long history of drug use, in and out of correctional facilities, on and off of opioid treatment programs, methadone clinics, you name it, I went to it. At that point, I was so medicated all the time, and I had so many other things going on that hepatitis C was way, way down here on the list. You know, like I was, you know, more worried about getting shot in the head or, you know, going and catching a prison sentence than I was hepatitis C. But
Orlando. I don't even remember meeting Orlando the first time I apparently met him, because he was so not interested in what I was doing. He had hepatitis C, he was at his methadone clinic. And then something changed. He decided, okay, now is the time to deal with this.
you don't know how. Can I play?
Yeah. So you get a nickel?
Okay. A nickel. Oh, gets a nick. Nobody asked me to, you know, piss in a bottle or have you been doing this or have you been doing that. Nobody threatened to throw me out. I just said, okay, you're here. Glad to see you. When you dictate my hierarchy of needs to me, then you're disempowering me. I know what I need, and I know what I need and in what order I need it in. You know, if you want to be a partner with me in that, that's great, you know, but if you go tell me, well, I can't do this for you because you have to go jump through these 10 hoops first, and, you know, we want to see how high you jump, and we don't want you to come down till we tell you to. I'm not going to respond to that. That didn't happen here. That did not happen here.
All right, so what are some things that stood out to you about that video? You can drop stuff in the chat or raise your hand and we can unmute you to speak, it looks like. Which would be great. I think coming off mute would be great, but Anne says environmental factors discussed, not addressing health concerns, shame of addressing health substance use concerns, motivational interviewing, empathy and active listening applied in the program he accepted. So yeah, that's a lot there. So we saw, first of all, like we talked about, you know, when somebody's conditions are such that they cannot focus on, maybe their goal is to change their drug use or to work on it to cure an infectious disease that they have. But when you're focused on if you're going to get shot in the head or a prison sentence, like Orlando said, he also talked about, yeah, the environmental factors of just being in a community where that was part of it. I see extremely low barrier is really what worked for him. Yep, it was a safe place free of judgment. Yep, empathy, non-judgmental approach to care, meeting people where they are. I'm loving all of this. So we have Kelly, do you want to come off mute? I can't hear you, Kelly. I don't. Yes, there you're on. Now we can't hear you. Okay, well, Kelly, if you can come off mute and chat, your hand is raised, but I couldn't hear you, but I'll just keep saying in the chat here, we've got, yeah, talking to him and not at him. One thing I've been thinking a lot about lately, for myself, because I have been in, you know, abstinence-based recovery for some years, but I just was reflecting on how little I ever was asked about what I got from using drugs by anybody. And, you know, this kind of low barrier service is so nice for people to have access to. Like, you know, if you're someone who's used drugs or had a substance use disorder, you probably know that, like, you didn't need a bunch of people to tell you that, you knew that yourself. Internalized stigma can be the hardest thing to overcome. And so actually having and maybe, you know, you're going to get that from family. Family's not going to be able to just say, we love you no matter what you do. But this clinic and where you all work, you can be that person. You can be the person who keeps welcoming Orlando back and giving him a hug and not having any attachment to if he uses more or less drugs. Oh, Kelly, we can hear you now.
Wonderful. You know, I was sitting here reflecting, and when I saw the streets of where Orlando was walking, those were my streets. And I am a survivor of hepatitis C myself, and Diana Silvestri was one of my doctors many, many years ago. And I remember having the stigma and wanting so much to if that was out there for me.
Kelly, can you get a little closer to your mic? It sounds like, I don't know if you have headphones in, but it's real choppy.
Can you hear me now?
A little bit.
Okay, I'm so sorry. Can you hear me now? Because I'm in the hospital. Can you hear me?
Yeah, that's better.
That's better.
Well, I just recognized where Orlando was because I'm from there. And I am a survivor of hepatitis C. I remember when I was diagnosed that I was in such denial of that. And being, having this addiction and, a field user. And I just thought nothing was, I could not hit me. And that there was nothing out there for me, and there was nothing for me to have like tried with. And actually Diana Silvestri years and years ago, and I was really, really young, reached out. And we have to look at all the whole picture, the whole ingredients of our people and our humans. And when I was hearing him talking, I heard like what he was saying was able to find a safe plan, and that's what I hope, and that's what I want to put out there for my patients, is that I am a safe plan, and that I can and I will support you, and you can, and hopefully I can bridge you, you or free condoms or type C clinics, whatever I can, because all those ingredients make this human. And so this really hit home for me. I'm so thankful that you showed this video.
Yeah, thank you, Kelly. Thank you for sharing that with all of us. And yeah, we're going to show a little bit of a follow-up video of kind of what happened with Orlando later on. That's also really exciting. It was hard to hear everything you said. It's still choppy, but thank you for sharing that hit home for you and your own personal experience with it, and how yeah, this video is really beautiful and can always help just in of itself remind us how to get back to really focusing on treating people with dignity and care. And so let me share my screen again. We're going to now go into the 6 principles of harm reduction. Here they are, but we're going to go one by one. So I'll just skip this and start in on that for time. So here's Orlando again. And the first one is health and dignity. I've been saying that a lot in my time on this presentation, because it really is the number one most important thing. Well, all of the principles are really important, but you know, health and dignity is kind of what the center of harm reduction really truly is. And so it's establishing a quality of individual and community life and well-being as the criteria for successful interventions and policies. And so it's not saying that the criteria for success of your program or for success of somebody's own journey has to do with anything except for the quality of their life and well-being. It doesn't say that stopping using drugs is what success is. It says their health and well-being. And so really thinking about that as what is really central to harm reduction and the harm reduction approach.
Great. Yeah, and I think you all see a lot of these in the video from Orlando, and we're going to go fairly quickly through them, but I think seeing how they were represented in the video is really brings them to life. So the second is participant-centered services, calls for the non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. That seemed to be like your number one takeaway from watching Orlando, was that Oasis Clinic was non-judgmental and non-coercive. You could drop in and have pizza for a year. You could come and get your Hep C treated. And by building that, giving people actually service and resources they need, they engaged in services more.
Yeah, and I mean, this is what California Bridge is also. Like, California Bridge is a program that's modeled off of being non-judgmental and non-coercive, and really just being there for people when they are ready. And if that means coming back over and over, then they're still welcomed back, which is so incredible. Participant involvement. So we talked a little bit about this. When we're able to do longer trainings, we get into this a lot more in terms of like, what can participant involvement look like in a hospital setting? Sometimes that can be a little bit tricky, but there's many ways to ensure that participants and communities impacted have a real voice in the creation of programs and policies designed to serve them. So that may mean hiring people with lived experience to be sons. It could be something like having surveys, or just asking questions to participants. Hey, how is this working for you? What would you like to see changed? Do you have any feedback for us? But there's so many different levels that participants can be involved, or clients or patients, and really focusing on the real voice part, because there's also a lot of ways to just kind of tokenize and just kind of, go through the motions, or say that we're including people, but not actually really think about what does meaningful inclusion look like.
And the last of the 3 participant ones, we have participant autonomy, which is that it affirms participants themselves as the primary agent of change, and seeks to empower participants to share information and support each other in strategies which meet their actual conditions of harm. So we've talked a lot about not determining what the greatest violence is in someone's life, but allowing them to do it themselves, right? So what hadn't worked for Orlando was saying, like, you got to treat your Hep C over and over, right? What worked was allowing him to be the primary agent of change to address his needs to feel physical safety on the street, his needs to, not get in trouble with the police. And then once he had information about his Hep C in a non-judgmental way, he shared it with other people, which we're going to see in his story, right? That empowered him to share information, to support his community, and to address his actual health. So by giving people that level of bodily autonomy, we allow for greater health and dignity, to bring in the other principles. So really centering people's bodily and, other kinds of autonomy.
And then the next one is sociocultural factors. So we talked about this a lot in the why do people use drugs, that, you know, and also in the philosophy of harm reduction, or the harm reduction as a movement, and the social justice aspect of that. So this is recognizing that the realities of various social inequalities affect both people's vulnerability to and capacity for effectively dealing with potential harm. So we saw that Orlando identified himself as someone who is more vulnerable to getting caught up, he said, based on where he lived, the community he was a part of. And so in the same way, we talked about people's we didn't say the word capacity for, but I think talking about what kind of support someone has to get access to care, treatment, other kinds of health services as well, childcare, financial support, whatever it might be, to help them address any kind of health issue that they're wanting to address. And so again, like a lot of this has to do more with social inequality, with structural oppression, with policies, and not necessarily just with the drugs themselves or a person's drug use.
So we have pragmatic and realistic, which I think is a really important last one, which is that harm reduction does not attempt to minimize or ignore the real and tragic harm and danger associated with licit and illicit drug use and other risk behaviors. So, you know, it's important that we say there are real harms in terms of interpersonal, physical to our bodies, right? So you can have strained relationships, have issues with your physical health, as well as a ton of other harms associated with using drugs. And we are not pretending that those don't exist. We are addressing those, and also knowing that approaching people from a harm reduction, non-judgmental perspective can actually address some of these harms. And so being real with people when you see them come up. And we're going to watch a little bit more about sort of how the harm reduction approach worked for Orlando. So you saw his experience and his words, you saw the principles, and now what did that mean for him in his life?
Fortunately, he was one who we managed to treat with interferon, get him up to a meaningful dose, and keep him there. And lo and behold, Orlando was cured. Boom, he was normal.
The minute I found out that I had a virus, I wanted to let other people like myself know. You know, a lot of them just weren't aware of the facts. So when I came here and I started being educated about the facts, I didn't keep those facts to myself. You can't beat what you don't treat! You can't beat what you don't treat! I told my peers, did you know about this meeting? You know, did you know that there's treatments? Did you know how it spreads? A lot of people were just in the dark about it. Nobody had talked to them. Nobody had talked to them, not at the emergency room, not in the correctional department, not anywhere. They'd never had this kind of conversation.
It doesn't matter what state of chaos you're in. We see people who've scheduled their, Oasis Clinic visit months in advance, and we also see people who kind of rolled in off the streets and they heard that it's Hep C and pizza. And we like them all. It doesn't matter to us. This is a wake-up call. It's just not for you.
I love her.
So what did you all notice in that video about what it meant for Orlando to be approached from harm reduction? And how would you apply this approach in a hospital setting? And again, you can put it in the chat. As y'all are styling those in, Kelly, I was so glad you shared your experience. I also live in Oakland and knew Orlando and Diana Silvestri and saw the amazing impact of their work. And I think beyond even what this video shows, Orlando went on to be one of the people who made Hep C treatment under Medi-Cal able to exist for people who use drugs. He lobbied, he gained political power, as well as, ending up passing away as a Hep C navigator at Glide in San Francisco. So the harm reduction approach changed his life, and it also changed hundreds of thousands of people's lives in California.
And yeah, because
So-
in a lot of states, Hep C policy requires that you be abstinent and have a positive or negative or that you don't have, that you have to take UAs and basically not have drugs in your system. And so changing the stigma around that has been huge. And like this video shows, people often need to address the symptoms that they're having from Hep C, and how that's, you know, giving them, it just physically can make it really difficult for them to want to address drug use at all. So we're seeing in the chat, yeah, it seemed to be important to him to give back, each one teach one. Yeah, absolutely. That's how things do get changed. And showing also that treating someone with, you know, using the harm reduction approach with someone actually gets them. I mean, he went further than just treating his Hep C. He ended up going and feeling empowered to actually be more involved in his community. And I think that is really powerful and important to remember. You never know, it could just be you as a provider who's actually the first person that's treated somebody kindly, not only all day, but maybe for years. And you could be playing a huge role in inspiring somebody to actually believe in themselves and, you know, be involved in their community. So, oops. Does anyone else want to comment on how you would use the principles and this approach in the hospital? I mean, I kind of just told you what I think you can do, but I would love to hear one or two people come off mute and just share. We don't have that much time left, but what have you already done, or what do you hope you can do to bring some of these principles into your work?
So giving out naloxone. So we'll go into some of those specific tools too. And if we don't get to all of this, you'll have the slides and the content, but actually integrating more tools and services. You don't only have to support people getting on buprenorphine, but what else do people need? And so naloxone is one of those things, preventing death, being able to take care of each other in your community. You're empowering people to have control over their own life by giving out naloxone.
Yeah, so giving them resources and tools. We've got the Never Use Alone hotline, other supplies for patients, looking at other barriers. If anybody wants to come off mute and say something, we're going to go through.
Emerson, if you want to come on mute.
Sure, thanks. Having been through all of that, the Hep C and, you know, and all that stuff that gentleman went through, I'm able to help our patients by sharing that it can be done. I mean, you know, I think for a lot of us, we're a model. We're like a beacon of hope. I know that sounds cheesy, but we really are. We offer hope to people that don't have any hope. And especially in our particular hospital and our demographic, we have a lot of homeless people, a lot of people on parole. I mean, just that's who our demographic is. And a lot of them don't think help for them is possible. And by me and others, like, you know, my coworkers, of being honest about who we are, where we've been, what we did to get well, it offers them some hope. So that's it.
Thank you. Yeah, so let's see. That was just Emerson, right? Okay, put your hand down. Yeah, thank you so much. And thank you for everyone who's sharing your own personal experience. I think it's really important to remind, for me anyway, you know, often to go back and remember, like, what was it like for me accessing services, and what helped me and what didn't, and what worked for me and what didn't. So since we don't have a lot of time, we're going to go through the services here. that are available, but Savannah and I are always around. You can reach out to us. I mean, Charles also knows a lot of this stuff, but if you are wondering what else can I do related to services, but the kind of takeaway here is that you don't have to actually have access to all of these services to treat people well. That's where it starts. But there's syringe access and disposal. There's safer drug use supplies beyond just syringe access and disposal. And there's overdose prevention. So we talked about naloxone, safer sex materials. There's MOUD, that's what you already are, that's what you're already doing. There's safer consumption services. So that's something that we don't currently have in California, but there's a law right now, SB 57, that's moving through the legislature that would allow for certain cities to have places where people can bring their pre-obtained substances and use them in a kind of controlled setting, meaning that there's it's sterile, they're out of the elements, they have people there should they need other resources or experience an overdose. Drop-in centers are places where people can just go and get lots of other kinds of services, or just have a cup of coffee, you know, watch TV, be in out of the elements, connect with other people. Housing First is basically a lot of what we've been talking about too, related to other things like treating the person, the needs of the person before looking at their drug use. So allowing people to access housing, even if they're still using drugs. And then referrals to all kinds of other services. So that was a very fast run through of some of the different services that are part of harm reduction.
And I think we wanted to think too in our last couple minutes, 2 minutes, about what the tools and services are you can offer. So if you go to the next slide, this information is here and we're available to you all, but as Sherry said, there's lots of hospitals doing naloxone distribution. You can do that. You can distribute it directly to people who use drugs in a low threshold way with minimal data collection, and you can get it for free. This was a huge lift for California Bridge to create this model for hospitals, and you have this beautiful model of doing this that is so inspiring. So take advantage of being a hospital that can provide this. And then the next one is Syringe Access, which some hospitals have taken on, and we know they have decades of evidence to support their benefits, and offering these tools. I never even finished the sentence in that slide. So, you know, you can offer these tools, and there are multiple legal ways to distribute safer drug use supplies in California. So please reach out to us. And I think the other thing to know is that it is incredible to provide people sterile syringes when they need them in that moment, 24/7 in the hospital. That is like so beautiful. And also, before you get there, or if you can't get there, build relationships with people in your community who are doing that work, so that, as I said in the beginning, you can make sure that there's a referral. Like with Orlando, he was at his methadone clinic and they didn't do Hep C treatment, but he found Oasis through a referral, through a connection, and that's where the impact was really made. So making sure we continue to do that. Those are super quick rundown. And then the next takeaway is what Jenna already started to say, if you go one more, which is that really this is about combining the principles of harm reduction with tools and services to actually be practicing harm reduction. I don't know if you want to add any last things on that, Jenna.
Yes, I will add something I've actually never said in one of these trainings, but I'm feeling kind of, I don't know, passionate about it today. So it's that if you've heard what we've said today and you still think that offering someone supply access for safer drug use is enabling them, reach out. I would love to have a conversation with you. I think that that is the dominant narrative. That's what we're hearing everywhere. And having now been working in kind of policy advocacy, I can tell you that that's where all the money and resources for the most part are being poured, right? Into making sure that people get treatment to stop using drugs. But we've been trying that for years and years. And what we know is that we have to have this other approach for people. And that for me, the challenge is always to learn how to, when we talk about being non-judgmental, when we talk about somebody else's autonomy, a lot of times it's us that need to work on ourselves. If you're burnt out because what you're dealing with every day is really hard, it could be triggering, it could be painful, all of that. Our burnout sometimes is what gets in the way of us actually treating people well. And instead of being non-judgmental, it leads us to be really critical and judgmental about somebody. And so a lot of this, I think, is work that we need to do on ourselves to be able to show up and be able to kind of let go. I am not responsible for this person's success or failure. You know, I am here today to treat them well and to kind of let go of the rest. And so if you ever want to talk about this stuff, it's something I've spent a lot of time mulling over, and I'm just always open to share my experience and also just hear from you what's coming up. So thank you so much.
Thank you so much, Savannah and Jenna. I really appreciate it. It's 12 o'clock now. Well, we understand if you have to leave. I am going to post the evaluation for this lovely presentation. Thank you so much, Jenna. I just, you know what, you guys, they never fail to impress me. And we will have them back. Obviously, we have so much chat and so many questions. I know we did post your emails for both of them if you needed to contact them, but we will have them back, I promise. We always collaborate and partner. So thank you. And if you can stop sharing so I could put the evaluation up. And any last minute words? All right. Thank you.
Thank you all for having us.
Awesome. Here is, if you please fill out the evaluation for credit. I know somebody's going to put that in the chat. And again, our California Bridge resource list. We are still on Twitter and Facebook. And please feel free to reach out to our mentors. We have our mentor team, and they're a very great contact. And now we've made it easier to contact them, mentors@cabridge.org. So you can contact all of them. It really makes it simple. You don't even need to know who your mentor is, and they can get you in contact. And again, it's me. If you didn't get the chat, did we put that in the eval? Hold on. I am trying to do that now. And again, thank you. Thank you very much. We are looking for the chat. Hold on, you guys. Okay, we can't get the chat to you. We will send a follow-up email. So if you fill out the evaluation on your follow-up email, and we thank you very much. Sorry we went over, and we will see you in September. I do want to put out the challenge for August is National Overdose Awareness Day at the end of the month. And we challenge you to promote or bring awareness to your hospital. So we're looking forward to our sites doing something. It might be just an email, a flyer. It might be whatever you guys can do to promote awareness of National Overdose Awareness Day on August 31st. Bye, guys. See you next time.